multiple endometrial cysts. It was a 20-year-old Arabian mare and was referred to the clinic after the end of the breeding season for a reproductive evaluation. The owner reported to us that the mare had been bred multiple times over the previous 2 years without becoming pregnant. And they reported that the mare had had 6 foals by embryo transfer and had carried 3 foals herself to term during her lifetime. On arrival, an ultrasound examination was performed. She had multiple medium-sized follicles present on her ovary. There was no corpus luteum visible. There was slight uterine edema present and no free fluid in the uterine lumen. But we did notice multiple large endometrial cysts throughout the uterine lumen in both horns and in the uterine body. This is a video of the ultrasound exam. You can see starting with the left ovary, traversing down the left uterine horn. The black areas are uterine cysts. Up the right horn, multiple cysts again present in the right horn as well as the left horn. Coming down the base of the horn again. And we'll traverse down the uterine body, again, multiple cysts present throughout the uterine body. Additional diagnostic procedures were performed, including a double-guarded uterine swab for microbial culture, which was negative, no growth of bacterial organisms. We collected a uterine brush for cytology, and there were no white blood cells noted. We also took a uterine biopsy, and the report came back with minimal fibrosis and no significant inflammation, and a Kenny grade 1A, which was very unexpected based on at least the mare's age and the presence of all the uterine cysts and a history of subfertility. We went on to perform a video endoscopic exam of the mare's uterus, which we will watch next. We're in the uterine body, and we can see 2 large endometrial cysts on the left-hand side of the video. We're at the bifurcation, left horn on the left side of the bifurcation. We're going up the right horn now, and we can see a couple endometrial cysts present along the wall of the upper part of the wall of the uterus. We'll slide the endoscope forward here, going up to the tip of the right uterine horn. We can see the uterotubular junction present here. We'll back out of that horn. We'll go up the left uterine horn, another cyst present in the left horn, pass the endoscope up to the tip of the left horn, and we can see the uterotubular junction over on the left side of the cranial tip of that uterus. Nice papilla visible here. So we had talked to the owner previously, and we contacted the owner again, and they granted us permission to perform a laser ablation of all the endometrial cysts. That's why the mare was referred to our clinic. And the goal was the mare would go home after the laser procedure, put under lights around December 1st, and then return to the clinic in February of next year for a reproductive management. So the mare was put in exam stocks. The mare was sedated with some ditomidine and butorphanol. An epidural was placed, and that consisted of 5 mils of lidocaine plus 100 milligrams of xylazine. And the goal of the epidural was to inhibit straining and provide regional anesthesia. Tail was wrapped. Mare was palpated to remove feces from the rectum. The perineal area was cleansed multiple times and dried. Then a video endoscope was passed up through the vaginal vault, through the cervix into the uterine lumen. The uterus was inflated or insufflated with filtered room air, and a diode laser was used to ablate all of the cysts in the uterus greater than 1 centimeter in diameter. This is a video of the laser ablation of the cysts. We'll just watch one cyst here. The laser is being applied to the surface of the cyst. And as we'll see, the cyst will deflate, and as it decreases in size, the laser therapy will continue until that entire structure is ablated. And that would be continued for all of the cysts that we saw during our video endoscopic examination. After the laser therapy, the mare was administered 500 milligrams of flunixin-meglumine. The uterus was lavaged with lactated ringers, and a gram of ceftiofur antibiotic was infused into the uterine lumen. The mare was sent home for the winter with, again, plans to return early the following year. But she didn't. She didn't come back until May, and an ultrasound exam at that time revealed that more cysts were present again in the uterus. And whether or not the original cyst had recurred, probably not, and it was likely that just new cysts had developed in the uterus. The mare at that point did have a corpus luteum on one ovary. She was administered a dose of prostaglandins, a brand name Estromate, 250 micrograms as an intramuscular injection. About a week later, she was developing a modest-sized follicle with edema and a small volume of slightly echogenic fluid in the uterine lumen. Semen was ordered. A dose of deslorelin was administered. Once we had semen confirmed, semen arrived. The mare was inseminated the following day, and ovulation was confirmed after the insemination. Embryo collection 7 days post-ovulation on that cycle, no embryo was recovered. We again talked to the owner, and the owner agreed to a temporary cyst deflation procedure. Not terribly proud of doing this, but it did work. The mare was sedated with etomidine and butorphanol again. Video endoscope was passed up into the uterus, and an endoscopic biopsy instrument was used, passed down the biopsy channel and used to puncture and deflate all of the large cysts, again on a very temporary basis. This is a video of that procedure that was performed in this mare. We can see again the presence of a large uterine cyst. This is a biopsy instrument. Again, it was passed down the biopsy channel of the video endoscope. We're simply going to disrupt that cyst and drain it. And we did this with all of the cysts present in that uterus, hoping that we might gain some advantage in breeding the mare and trying to collect an embryo. While that mare was still in heat, we examined her the next day. She had a 42 millimeter follicle and good uterine edema. Again, semen was ordered from the same stallion, and the mare was given a dose of deslorelin. The mare was bred. Sperm motility was good, 72% total motility, 66% progressive motility. We had a second dose of semen. It was put in the next day, and ovulation was detected the morning after that. This time, a uterine lavage was performed 8 days post-ovulation, and we did recover a blastocyst stage embryo and transferred that into a recipient mare, and that recipient was confirmed pregnant at 12, 14, and again at 25 days of embryo age with a heartbeat. The mare was bred on several of the next cycles, and we did collect embryos on 2 of those cycles. Ultimately, 2 ongoing pregnancies were generated. One pregnancy was lost between day 25 and 35, and the other pregnancy carried to term. Now, uterine cysts are very common, especially in older brood mares. They've been estimated at present in at least 55% of subfertile mares greater than 10 years of age, and a majority of horses that are in their middle teenage years or older will have one or more uterine cysts. They are associated with pathologic changes like endometrial fibrosis, and that's why we were concerned that the uterine biopsy was reported to be a 1A. Uterine cysts have the possibility of adversely affecting maintenance of pregnancy if the cysts are large or numerous in development. And they certainly can complicate a pregnancy diagnosis. Some uterine cysts are very round, very spherical, and may look like a 12 or 14-day pregnancy. The clinical significance of uterine cysts depends on the number of cysts, the size, and the location of the cysts. Potential problems associated with uterine cysts: they may impede embryo migration throughout the uterus, which is important for maternal recognition of pregnancy in the mare. They could decrease nutritional support of the embryo. That's also associated with the presence of fibrosis. And again, they may interfere with our ability to see an early pregnancy, especially if there's twins. There are two general types of cysts: glandular cysts. They're very small, caused by scar tissue surrounding the glands, causing cystic distension of the glands, and that's a biopsy diagnosis. We can see a nest here of glandular cysts in a uterine biopsy. The other type is lymphatic cysts. These are the larger ones, again caused by scar tissue surrounding lymphatic ducts, also possibly inadequate myometrial contractions and poor drainage of the uterus, and that's an ultrasound diagnosis. That's generally what we're faced with these large visible uterine cysts. They're most commonly filled with relatively clear or non-echogenic fluid. Occasionally, we'll see cysts that are filled with somewhat echogenic material. Cysts may occur singly or in multiple clusters throughout the uterus. More often than not, they're located at the base of one or both uterine horns. Some are broad base on the endometrial surface, and others are in a cluster on a membranous stalk. As they interfere with our ability to detect pregnancy, some smaller cysts may look like an embryonic vesicle, and occasionally, not commonly, but occasionally, we have to wait till about 25 days to see if we can find an embryo proper with a heartbeat in amongst a group of cysts. So here's an embryonic vesicle with the embryo proper tucked in between two endometrial cysts. A general guideline is that cysts don't grow and cysts don't move within the uterus. If you're looking at a mare that may be 14 days post-ovulation and trying to decide if something is a cyst or an embryonic vesicle, you can recheck the mare. And if that structure is located in a different spot, and if it's larger, then it's more likely to be an embryonic vesicle. If it stayed in the same location, as in it didn't move and didn't get any bigger over the subsequent day or two, it's likely to be a uterine cyst. A standard recommendation is to map out the cysts prior to breeding the mare, so you know where the cysts are located, so that when you're doing a pregnancy exam, you can refer to that drawing. Diagnosis generally on ultrasound or an endometrial biopsy in case of the smaller cysts. Treatment options with small cysts that are, again, small in size and not very numerous. No treatment is generally required. There is a possibility of endoscopic guided laser ablation, as in the current clinical case. And there's a snare technique, which is very inexpensive, we'll describe in just a moment. And then there's a number of alternative treatments that have been described, but most don't work very permanently. So in some of these pedunculated cysts, as visible here on ultrasound, and then on a video endoscopic view of a cyst located against the uterine wall on a small pedicle, one can make a snare using a combination of two insemination pipettes taped together, and number 3, a nylon suture material can be used to make a snare with this, and that snare can be passed over the cyst and pulled up against the stalk, and in using a phytotomy technique, you can cut the base of that cyst and remove all of them. This particular mare had a series of cysts that were making it very difficult to retrieve fluid for embryo collection, and after we took the cysts out, it became much easier, and we were able to successfully get embryos out of this older mare. Take-home messages from this case is that uterine cysts are common in middle-aged to older mares. They are associated with an increase in fibrosis or scar tissue. They may make pregnancy diagnosis somewhat challenging. No treatment is generally needed if the uterine cysts are small in size and small in number. And removal should be considered if cysts are large in size or abundant in number, and options for cyst removal include laser ablation, the snare technique, or the temporary technique of deflation. If you want more information on cases like this or other issues associated with equine reproduction, please visit the website of the Equine Reproduction Laboratory at Colorado State University.